mechanics, and Kunal has given us idea about the implant designs. So I am going to talk on inserts in TKR. Modern poly inserts, they are designed to recreate the native joint mechanics. Now, biomechanics of knee, the femoral rollback and screw home mechanism, I won't be repeating it because it has been already talked in details by Abhishek. We all know about the role of PCL and ACL both in flexion and extension of the knee joint. Now, these are various types of poly designs that are available. The posterior stabilized, the cruciate retaining, the congruent articular surface, the medial pivot, then bicruciate retaining, and the constraint implants. So in posterior stabilized implant biomechanics, the implant uses the tibial post to function as PCL, which is sacrificed during preparation. This demonstrates the paradoxical anterior translation of lateral tibial condyle relative to tibia during the normal gait. Now, during deep flexion, the posterior stabilized TKA shows normal internal rotation of tibia with progressive knee flexion and femoral rollback. The reason for this is post does not engage the cam during normal gait. During deep flexion, the post uses cam as a lever to induce the normal femoral rollback. In cruciate retaining biomechanics, the PCL is retained and the ACL is sacrificed. It decreases the shear forces over the femorotibial interface by decreasing the posterior translation. During normal gait, the paradoxical external rotation and anterior translation of tibia is seen. And during deep flexion, the tibia paradoxically rotates externally and femoral rollback is not restored. If the slope built in tibial component is more than 3 degrees, the femoral condyle demonstrates the normal femoral rollback during 20 to 90 degrees of flexion. If the slope is less than 3 degrees, the rollback does not occur. The outcomes of CR and PS knees, the CR TKA survival is around 90% and PS is around 77% at 15 years. In PS knees, the polythene post can rupture and femoral components can jump the post in unstable knees. The removal of bone in the intercondylar notch in PS knees can cause fracture of the condyles. The overall range of motion is less for CR knees as compared to PS knees. Then the congruent articular surface, the PCL is sacrificed and there is no post-cam mechanism. The PCL is substituted by higher anterior and posterior lips. The advantage is there is no box cut, so bone is preserved. It distributes forces over large surface area, avoids the risk of cam post mechanism fracture. The posterior wear is less and jumping of the post is less. The drawbacks are increased surface area leads to increased wear characteristics, decreases the range of motion in deep flexion as posterior lip prevents the femoral rollback. The next one is the medial pivot. In normal knee during flexion, the medial femoral condyle pivots and the lateral just rolls back. The medial pivot poly design involves the concave shape medially with anterior lip or ball and socket mechanism and less congruent shape laterally, which is more flat, which allows the anterior to posterior translation. This avoids the paradoxical knee motion during gait and in deep flexion. The results are comparable to PS design. Now this slide shows the medial pivot knee, in which the medial side is more deep, ball and socket type, and the lateral side, which is more flat. The medial side, the knee pivots and the lateral rollback occurs. The lateral and dual pivot, the kinematic studies of knee have demonstrated the lateral pivot during early flexion angles while walking and running, and medial pivot during deep flexion. The dual pivot implants are designed to better mimic the natural knee kinematics by providing lateral and medial pivot point at lower and higher flexion. This improves the function of knee. The bicruciate knees, I won't go into details because Kunal has already talked about it. Both the cruciates are retained. But the drawbacks of bicruciate retaining are more polywear because of the two different inserts, the differential subsidence of the base plates, malalignment of the tibial base plates, higher revision rates, and retained ACL may not be physiologically fully functional in arthritic knees. And in varus and varus consent knees, the taller and wider post constraint in femoral box to prevent the coronal instability. It is used in severe varus or valgus knees, incompetent MCL, flexion contractures where knee cannot be balanced. The drawbacks are accelerated wear of the poly, the component loosening, permanent damage or breakage of the post, failure of the poly locking mechanism, and higher revision rates. Now this slide shows the upper one, the regular poly, and the lower slide shows the constraint poly. The constraint poly is obviously thick and tall, so it imparts more stability to the knee joint. A metal back tibial tray and all poly inserts. The metal backing of the tibial tray improves the load distribution on tibial condyles and protects the osteoporotic bone. It also allows the use of different thicknesses of poly inserts and long stems or wedges in revision cases as per requirement of that particular knee. The micro motion between the metal tray and the poly insert generates lot of polywear debris on the back side and over non-articular surfaces and causes osteolysis. So this is backside wear. Fixed and mobile bearing polys. The mobile bearing design generates less contact stresses under tibiofemoral malalignment conditions and less wear rate. The mobile bearing knees have better range and survivalship of both the knees is same. Now, what poly is made up of? Poly is ultra high molecular weight polyethylene. The molecular weight is 2 to 6 million units. The highly linked cross poly or gamma or electron beam radiation of the ultra high molecular weight polyethylene, it increases the wear resistance. Annihilation is the hitting of the poly below the melting point or putting it in vitamin E or irradiating in 3 sequential doses followed by annealing has led to second generation highly cross-linked poly that has good wear and improved mechanical and fatigue properties. Sterilization of poly gamma radiation helps cross-linking but creates free radicals. These radicals affect mechanical and fatigue properties of poly. So ethylene oxide and gas plasma sterilization, which do not produce cross-linking and do not generate free radicals, that has come into practice. Then poly locking mechanisms. The tongue-in groove or dovetail grooves in the tibial tray, they match the corresponding areas of the poly insert and it locks. And peripheral rim locking, the circumferential raised locking rims around the tibial tray, they help in locking the tibial insert onto the base plate. Thank you.